Good afternoon, everybody. My name is Geoffrey Sher. Many of you have met me already at these weekly webinars that we hold every Saturday, with a few exceptions, like I've got this one coming up next week, will be on Thursday, because I have my grandson's wedding on the weekend and I won't be able to be available, but I'm going to make up for it by doing a webinar on Thursday coming. But we'll talk more about that later. Firstly, let me say welcome to you. I'm a fertility specialist. I've been doing this work for almost 40 years, and I've been very much involved in the development of the field of in vitro fertilization, having opened the first non-university private IVF program in America in 1982. That was also the fourth IVF program in the country, all in all. Now there are thousands of them. So I've been around from the year dot. I've seen this field evolve so much so that I recently have written a biography, which hopefully will come out soon, on my life in this field. But anyhow, I've loved doing these webinars because I get to speak to people from all over the world. The one we're doing today is exceptionally interesting because it's had the biggest response of all the webinars we've done. It's on the topic of endometriosis, and I have some very important and unique perspectives that I want to share with you. And we'll be talking about this later on. But firstly, to say welcome to every single one of you. This is a little introduction, is to get people onto the webinar, asking questions, so I can answer a couple of questions in advance. And when we get up to over 100 or so people already engaged directly with questions, then I will switch over, make a brief 10-15 minute talk on the topic, and get into questions and answers for about an hour and a half to 2 hours, when you'll be able to ask me any questions you like on infertility, IVF, with special emphasis on endometriosis and how we deal with things called endometriomas or cysts in the ovaries with endometriosis, and the role of surgery. I think you're going to find it very, very interesting today. So we're going to start off with a couple of questions that you might want to ask, and from there we'll go into the talk as soon as enough of you have engaged.
Perfect. Welcome everybody, welcome into the live stream. We are answering questions today on a special topic that we always get good results on. We love to share about this topic. We have endometriosis today, and endometriomas is what we're talking about. And Dr. Sher, in a little bit here, is going to go into a very depth webinar for you guys and go into depth about the topic. But in the meantime, we've got some special resources today, unlike other days. We typically only ever offer one article per session, but today with our endometriosis session, we have two exclusive articles for you guys today. One on sclerotherapy, and the other a re-established version of another article we've given you guys, but even more edited and more resources inside there for you guys. So go check that out. All of those resources are in our bio. Additionally to those two free articles you guys can get, there are two ebooks in there that Dr. Sher has written with his team out in New York, and there's everything you need to know in those books from IVF. So go check those out. In the meantime, we're going to answer questions and get some information out to people. I'm going to answer Therese. She says, I am 43, did lab surgery for endo S3. Should I do transfer right away or Lupron suppression first?
You're going to hear a lot about this, but I personally am against Lupron suppression. I don't think there's any benefit, because once you stopped it, it only takes a few weeks and you're back where you started again. I don't think Lupron has much of a place. In the past, we used to use it for months, thinking that it would cause the ovaries to stop producing estrogen. And you know, the hormone estrogen fuels the development of endometriosis. So by giving you Lupron before starting the cycle, we suppress the ovaries' estrogen production. Here's the problem. There's some downsides. If the ovary stops producing estrogen, you go into a kind of a pseudo-menopause. And that's got the effect of mopping up all the estrogen that your ovary produces. So the two things happen. One, there's not the ideal priming of the cycle for stimulation. Two, if you stop the Lupron, within a month of stopping it, the endometriosis is back where it was to start with, so it doesn't really help. And the third one, there's another downside, is it interferes with estrogen recognition by the uterine lining. And estrogen is what makes the uterine lining develop, and the uterine lining is where the embryo attaches. And if it's too thin, the embryo's roots can't attach properly. And if you're deprived of estrogen for several months, the uterine lining forgets how to respond. It doesn't recognize the estrogen. So you often end up with a thin lining. And that creates a real problem when you put the embryo back. So for all of those reasons, I'm against the use of Lupron. There are other things with endometriosis we're going to talk about as I go through my introductory talk later on, which will help explain your situation to you. So hold on for a few minutes until I give my webinar, and all these things will be pretty apparent.
Awesome. If you're just now scrolling in, we're just now starting our live stream for the day. We go live every Saturday for about 2 hours on a session, and today's session is a special one. We're doing endometriosis and endometriomas, and we have 2 exclusive articles for anybody who's in today's live stream today. You guys will have access to them. They are exclusive to you guys. At the end of the live stream, we get rid of them. So you have about 2 hours to go get access to them. We encourage you to listen and learn on this live stream, but in the meantime, if you want to have resources for after the live, you guys can go read all of that. There's articles that we've written for you guys today that are exclusive. No one's got to read them before. They're ready for you guys. You guys are welcome to share them once you have access to them. Everything is in the link for you guys, so go check that out. We're going to answer a few more questions here while we have some time. We almost got 100 people in the chat, so help us get up there. Share the stream, like the stream, help us get to 100 people. We're going to start our session in a second here, but I'm going to answer a few more questions. Let's go back up to the top. I want to make sure we get everybody answered. Kari Kar says, does endo cause bad egg quality? If so, can egg quality be somehow improved? Question mark.
This is something I'm really going to go into. When I do my webinar in about 5 minutes from now. So if you'll hold on, I don't want to repeat myself. So if you'll stick around, and everybody should for that webinar, listen to it. There'll be some very important information there that I want to share with you.
Sherry Han 1805 on TikTok says, having a typical hyperplasia and doing biopsy every 3 months plus Mirena coil, how long will lining be normal?
If you've got endometrial hyperplasia, and it's what we call benign cystic glandular hyperplasia, very often seen in women who have got PMOS, or used to be called PCOS, or women who are not ovulating normally, then it's not a problem. It's not premalignant. But if you've got changes in that thick lining that are premalignant, often referred to as endometrial dysplasia, that's another story. It's got to be dealt with, and it's got to be treated. And you've got to be sure that that endometrial hyperplasia is no longer a problem before you do IVF and transfer embryos. And if there's any sign of malignant tissue in the endometrium, obviously that's a whole different ballgame. You may need to be focusing more on your health and well-being if you've got endometrial cancer, and that often requires surgery, including hysterectomy. So I don't want to go there, but if there's no malignancy and it's either benign cystic glandular hyperplasia or it is hyperplasia with dysplasia, which can be premalignant, the latter needs to be controlled, brought into line with appropriate progesterone therapy over time, or Megace, or whatever you're using. And then when everything is controlled through regular biopsies, you can go into a cycle of stimulation under proper observation and scrutiny.
Awesome. If you're just now joining the live stream, we're answering questions today on a special topic, endometriosis, and answering questions about endometriomas and other things that go on within that topic. We're answering all these questions today, and as much as we can, we're going to try to answer as everybody we can. In the meantime, if you don't get your question answered, we have 2 articles that are exclusive to you guys. Anybody who is in the live stream today will have access to them. All you have to do is click the link in our bio, go fill out the 4-minute questionnaire, and you have access to all of our resources up there. You have 2 free ebooks that are there for anybody, any time of the week, and then there's 2 exclusive articles on endometriosis for you guys only. At the end of this live stream, I'm taking them off. They're not there anymore, so go check them out. Yeah, you have about 2 hours of our live today. We just now started, so welcome in. There's a ton of comments, and Dr. Sher, we just hit 135 people in the chat. So thank you guys. Thank you for sharing. Keep liking. I think it's a good time to start the webinar here, Dr. Sher.
I want to say a few words before I start this webinar. Firstly, let me say that the presentation I'm going to do now is going to last 10 to 15 minutes. It's going to serve as an introduction for you to bolster the questions and comments you want to make. I urge you to please ask your questions. And those of you that don't get time to get them answered, you DM us and we will address those questions separately by virtue of a response by email. Okay, so before I begin, I want to draw your attention again to what Josh, who is the videographer that's been with me all along and who I love to work with most, Josh has told you about, but I want to go into some detail about it because I think it's terribly important for you to all understand. Every week I do these webinars. I do them on Saturdays usually, with odd exceptions. This last one I did a week ago was on a Sunday because Josh was unable to be here on that Saturday. This coming Saturday, I will also not be able to be here because I'm going to my grandson's wedding. So my webinar for this coming week will be on Thursday, this coming Thursday, and will be at, I think, 4:30 p.m. Pacific Coast time and 7:30 p.m. East Coast time. So those of you who want to participate, I'll give you the topic later on, but that is coming up this Thursday. There will not be one on Saturday coming. And the next one will be every Saturday thereafter again. We'll pick up where we left off. The topics will be presented each time for you so you'll know what they are. So in this particular webinar, if you want to, and I advise every single one of you there, every one of you that are attending, to go to my bio and look for the ugly picture at the bottom of my face at the bottom of the screen. Click on that. It'll take you to a couple of links. As Josh explained, the first link gets you access to 2 books that I've written. And one of them is written with my partner, Dr. Drew Tortoriello, who's the medical director of our program Sher Fertility Solutions in Manhattan, where we do all our work. And Dr. Drew Tortoriello and I work hand in hand. We've worked together for almost 2 decades, so we're like 2 peas in a pod, which is great for patients because they get the same from both of us. And no one person can look after a patient in IVF. So go and get those books. The one book is a 300-page book. It's one of the most recent books I've written, as I say, with Dr. Tortoriello. And it's going to be like an operational manual on all aspects of IVF, including what the topic is we're talking today. I wrote it with him about a year or 2 ago, and it's very soon to be appearing in the bookstores. But in the meanwhile, it comes to you as free, downloadable ebook. Doesn't cost you anything. We don't ask for anything in return. Automatically, it'll arrive on your internet, and you can download it and read it. The second book is one I'm very proud of, and we'll come into this discussion today too. It's on the immunology of failed IVF and the immunology of failure when embryos are good, or the cause of unexplained infertility, or the cause of repeated miscarriages. I'm one of the pioneers in the field of clinical reproductive immunology, and I have been involved in this field from the early 90s. So there's a lot that I share in that book that you won't get elsewhere. It's again a free downloadable ebook. Click on that link. The book will come to you without anything in return. Every single person who attends this webinar, every one of you, should get these books because there's no downside. And there's more information that's current, up to date, and will help you understand. Especially with endometriosis, where you're going to learn today that 1/3 of women with this condition have an immunologic problem. And I urge you to get these books and read them. Then there are 2 articles that are more current than either book. I wrote them, I just finished them a few days ago. They come to you also free of charge, without anything in return. All you got to do is click on that link, and you'll get 2 books and 2 articles coming to you. I usually only give 1, but this time I updated a recent article that I did in a webinar I did earlier on endometriosis. That one is available. And then there's a separate article I wrote on sclerotherapy, which you'll hear about today, for ovarian endometriomas. We have a clinic in New York run by Dr. Ravi Kumar. She runs the sclerotherapy clinic. I personally think it's the only one in the country. Frankly, I could be wrong, but I think it's the only one in the country. You really should listen to today's webinar, and those of you that have got endometriotic cysts should seriously consider access to the clinic we have in New York, where Dr. Ravi Kumar with me will take care of those endometriomas without you requiring surgery to do them. We'll talk more about that later. But again, very important that you get these articles, you read these articles, they're going to really enlighten you. So, with that in mind, there's one last thing I want to mention. So listen carefully, please. There's a third link that you can click on in the bio. You are not under any obligation to do it. What I do here, these webinars, got nothing to do with making a living. It has to do with me doing what I love to do. I've been doing this for almost 40 years. I've helped be influential in the births of more than 17,000 IVF babies. I've helped blaze a trail in the field of IVF, introducing things like PGTA, is genetic testing of embryos. I've pioneered the field of clinical reproductive immunology, and I've been very instrumental in defining and identifying the need and the approach to individualized protocols for IVF, among other things. And I want you to understand that you will be able to, if you want to, set up a consultation with me. You don't have to, and there's no pressure. But by clicking on the third link, for those of you that feel you'd like to get my personal input into your particular problem, and I'm very much involved in helping couples that are spinning their wheels, all you need to do is click there. And I urge you to do it earlier, sooner rather than later, because it's first come, first serve. I can't service everybody's needs. I'm only one person. So get your names onto the list. You click there, that'll immediately bring up a questionnaire, 4 to 5 minutes long, that you can fill in right here, and you should do it while you're on this webinar. And that questionnaire will appear on my office manager, Patty Converse's screen on Monday morning. She'll pick it up and she'll reach out to you. Now, you don't even have to take her call if you change your mind and you don't want to have the consultation. Or when she calls you, you can tell her, thank you, I've rethought it, I don't want to do it. There's no pressure on you whatsoever. But at least you have the opportunity to talk to me. And if you do, I will take that questionnaire, I'll convert it into a template. Patty will set you up for a consult with me. We'll go through that, through your particular problems in detail. It will be followed by me sending you a detailed report, which is about 30 pages long, because it covers the entire consultation and your particular situation. And I support it with literature and articles that I've written to further embellish it and give you the information you need. You'll get that report immediately after our consultation, within 30 minutes. And you're still not under an obligation. But if you do wish to proceed with us, you have the opportunity to do that. About 65% of people I speak to in 70 plus different countries end up coming to us and helping us help them through their treatment, where they'd have to spend about a week in New York to get treated by us. So please, from all over the country, if you're in the Northeast, you've got absolute access. You're right on our doorstep. Fill in that questionnaire and we will get back to you. And if you want to have the opportunity to talk to me personally, online, for an hour, there is a fee involved, but if you have insurance coverage, which most of you will have, and we're lined up with most insurance companies, we'll accept the insurance coverage for that consultation. If you don't, I'm afraid there's a lot of time involved. There's an hour of preparing, there's an hour of a consultation, there are letters, and then everybody that talks to me will also get access to me through my personal cell phone number, which is provided to all of my patients that I speak to. Everybody that speaks to me has total access to reach me by calling me, and I will respond immediately and we'll discuss any questions, and it's free of charge, those phone consultations. To have access to all of that, there will be a fee involved. And for those of you that are from outside the country, it's a modest fee, and it will basically cover that consultation and all future interaction that we have through direct communication through my cell phone if you need me. So that's enough to get started. I don't want to go into too much more. Please go to the links on the bio and take advantage of those resources. Okay, now, endometriosis is a condition where the lining of the uterus grows outside the uterus. Now, there are many theories of how that happens, but the most popular and probably the most important is one called retrograde menstruation. The woman who menstruates, if she has at least one tube that's open, will on numerous occasions or even all times, contrary to what you realize, not only bleed outwards through the vagina, but will bleed backwards through the tubes, and the blood will spill out through the ends of the tubes, which hang over the ovaries like shower heads. That blood contains menstrual blood, but also the cells of the lining of the inner 2/3 of the endometrium. That's where the baby grows. That's what sheds with menstruation. And that inner 2/3 we refer to as the functional endometrium, because that's where the embryo attaches, and that's what comes away with menstruation. But as I said, it's not only outwards through the vagina, also outwards, retrograde, backward menstruation through the tubes. If you do a laparoscopy on a woman with open tubes, you'll very often, if it's done during menstruation, you'll be able to milk this menstrual blood and tissue out of the ends of the tubes, and you'll see it coming out. Now, in that blood are cells that are alive, endometrial cells. And in all women, these cells attach to a membrane that envelops all pelvic organs, a thin membrane like a saran wrap, which is porous, through which secretions pass. But it envelops all of the pelvic organs like a saran wrap. And on that surface where these endometrial cells love to attach, they attach all over. By the way, this is in all women, not just women with endometriosis. In all women, they attach. And at first they grow. And they grow in response to the hormone estrogen produced by the ovary. They grow and they thicken. And they build up, but you can't see them with the naked eye. They are sololucent. They are translucent. You cannot see these deposits. There are little islets all over the show. And then something happens. You ovulate. And when you're about to ovulate, progesterone, the second hormone, is produced. It signals your immune system to send down immune cells called macrophages through the pores in the peritoneum into the secretions of the pelvis, and they seek out these deposits of endometrial tissue and they gobble them up like little Pac-Man, cleaning up the pelvis. And by the time the next period comes, they're gone. The room is tidy and clean, and the whole thing starts over again. That's normal. That's the normal situation. Now, in some women, and these are usually women that are take charge individuals, women that are type A personalities, overachievers, the type of women that are the go-getters and the professionals in their career, a credit to their gender. In these women who live at a slightly higher stress level, the immune response brought about by progesterone to cause these macrophages to clear up all these deposits is compromised. These are also women that are the type of women that many of you are if you've got endometriosis. These are women that go to Google, read up more about their condition than the doctor, and go to the doctor with chapter and verse. It's really important that this type of woman, like most of you are, will have slightly suppressed immune clearance of these deposits. And now, month after month, after year, they build up. And now these deposits start to bleed inside because the endometrial tissue is much more. And they bleed, and now the blood, which contains red stuff called hemoglobin, which is mainly an iron compound, leaves a telltale sign when it absorbs after the period's over. And these little deposits that you see are nothing more than the pigment of iron from the hemoglobin left in these deposits, and you see them through a laparoscope. When you do a laparoscopy where you put a telescope-like instrument through the belly button, you can see them. And now you can get rid of them by lasering them away or burning them away, called ablation. This is what doctors do when they do laparoscopies and they find these deposits. But the problem is they then come to you and say, well, we got rid of all these deposits we can see that look like little gunpowder birds or pigeon eyes looking back at you through the laparoscope. But they're wrong. Because for every one they remove, there are another 10 or 20 coming up elsewhere. You can't see the other 20 because they're not visible. They're still in the early stages. And these are going to form endometriotic deposits in the same way later on. And as a consequence of this, you cannot, let me repeat, get rid of endometriosis if it's there completely. And you've got it long before you can even see it. Women that are going to develop these deposits that you can see, this is what is in line for you when you're in your early years, in your early 20s or late teens. Doesn't mean you've got overt endometriosis, but the problem that it produces has already begun. And now, if you go in thinking you can remove these lesions, get rid of endometriosis, you're mistaken, because for every one you remove, there are another 10 that are in the process of developing. What do these deposits do? They release toxins into the secretions of the pelvis. And now the egg coming from the ovary that's going to swim across this river of toxins to get to the tube to be greeted by the sperm who's going to fertilize it in the tube are compromised in passing through what would otherwise, a good analogy would be like trying to swim across a river with alligators or piranha fish. You may get to the other bank, but not in a healthy condition. So these eggs now left the ovaries normal in the early stages, cross through this river of toxins to get to the tube where the sperm's waiting to fertilize it. And through the effect of the toxins, so-called little receptors on the surface of the envelopment of the egg, which look like a mini chicken egg, these receptors are blocked by the toxins, and the sperm can no longer easily penetrate the shell of the egg to fertilize it. So what happens? Even before you know you've got endometriosis, before you can see the lesions, you've got these toxins in the pelvis. And so that the egg cannot be easily fertilized, your ability to get pregnant per month is reduced sixfold. So if normally at the age of 30 or 34, you had a 20% chance of pregnancy per month and an 80% chance of pregnancy if trying for a full year, if your husband's fertile and everything else is normal. Now the chances are 2 or 3% per month and probably no more than 40% in 5 years. So these toxins, even before you can see the lesions, even before there's any scarring or any disease visible in the pelvis, are reducing your chance of getting pregnant so drastically that you've now got what we call reduced fecundity. So your chances of getting pregnant per month are reduced dramatically. It wasn't because the eggs were abnormal, it was because the eggs were compromised in the passage across this river of toxins. And all women with endometriosis, even before they know they've got it, no matter how severe it is, will have this problem. And as a consequence, treatment is not going to be served by doing intrauterine inseminations of sperm, even with fertility drugs, because the eggs have still got to pass from the ovary through that environment to the tube to be fertilized. And in the process, they're going to be compromised. I am very proud of it, IUI, intrauterine insemination, and the use of fertility drugs in association therewith, because I introduced it into the field of medicine in 1984, very, very long ago. And it's a very good procedure, but women with endometriosis are advised against IUI, because the chance of pregnancy is not improved over no treatment at all, because the eggs are going to be compromised in passing across the toxic environment to get to the tube. So, if you do surgery to get rid of the lesions you see, all you're doing is burning those you can see, not those coming up that are already causing this toxic effect. And that is why surgery to get rid of the lesions of endometriosis, that are these deposits I spoke about, in my opinion, does not improve your chance of getting pregnant over no treatment at all. So therefore, intrauterine insemination, surgery, doesn't improve your chance of getting pregnant if you got even the earliest of endometriosis. The only thing that improves your chances is to remove the egg from the ovary, from the follicle in which it grows, before it's exposed to the toxins. Fertilize it outside the body, and then put it in the uterus into what would be hopefully a safe environment where the endometriosis is not developing. It's outside the uterus, outside the body of the uterus. And then your chance of getting pregnant is improved. Provided two things: that the embryo you put in the uterus is healthy and competent and able to propagate a baby. Now, older women or women with diminished ovarian reserve have got a much less chance, unless they use a very individualized approach to ovarian stimulation that protects the good eggs as they develop, of getting good embryos to put into the uterus. That's why PGTA, a procedure that Dr. Tortoriello and I proudly introduced into the field of IVF 20 years ago, which is now a game changer in the field because it tells us which embryos are chromosomally normal. Even if the embryo that is chromosomally normal came from a woman that's older or a woman with diminished reserve, provided it's normal, it's still got a great chance of making a baby. So if you do PGTA and you know the embryo is normal, you're okay. So what else did I say? What else is the problem? There's a condition we're going to talk about today called ovarian endometriomas. That's where the endometriosis occurs on the surface of the ovary and eventually forms into a cyst, which bleeds into its interior with menstrual blood forming inside the cyst. And that blood decomposes. And when it decomposes, it gets to look like melted chocolate, hence the name chocolate cyst. Now you may think, if the rest of the ovary is okay, does it matter? Hell yes, you're going to find out later it matters. Because any lesion in the ovary, a tumor or a chocolate cyst, will irritate the connective tissue in the ovary around the cyst itself, causing the ovary to overproduce the male hormone testosterone. Let me be clear. You've got to have some testosterone to make follicles grow and eggs develop, because it converts to estrogen inside the follicle under the effect of FSH hormone. So without it, you're not going to make follicles, you're not going to make eggs. But too much testosterone is a completely different case altogether. It gets into the fluid of the follicle, and now it compromises the ability of the egg to develop properly during stimulation in the affected ovary. If the other ovary doesn't have one, it shouldn't be affected. But in the ovary with an endometrioma of more than 1.5 centimeters in diameter, that ovary is going to compromise the development of eggs in the follicles that grow in response to natural stimulation or to fertility drugs, because the egg can't develop properly in an environment where there's too much testosterone in the follicle, because it compromises egg development, compromises the follicle's growth, compromises estrogen production, so that you end up with eggs that don't develop properly. And now, when those eggs are fertilized, they are going to be aneuploid, the embryos. They're going to have chromosomal irregularities, and those embryos won't make babies. That is why endometriomas, if they're larger than 1.5 centimeters, should be removed 6 to 8 weeks before you do IVF. And only when they're gone and the ovaries had a chance to recover would the woman be eligible to be doing IVF. And IVF, as I pointed out, is the only way to get around the toxic pelvic environment, or scar tissue that forms around the ovary and tubes, to bind it down in patients who've got endometriosis that's more advanced. But then there's a third thing, and we're not going to go into big detail now because we've done this in previous webinars, which you can find on Spotify, which you can find if you go to YouTube and just punch in at Dr. Geoffrey Sher, and then it'll get you to all the previous webinars I've done. Some have been on the immunologic aspects of implantation failure, and that thin book that you get free of charge in the 2 books that we give you as part of the perks that are available to those of you that are here today. Those are also going to, that 1-hour book is on the immunology of implantation. And you'll be able to read this up there as well as in the articles that we're providing you with. So again, immunologic factors can affect the ability of an embryo to attach. And it happens because of two factors. Women with endometriosis, more than half of them, will produce substances, in their blood called antiphospholipid antibodies. It's an autoimmune response that occurs in women with endometriosis in 50 to 60% of cases. And that can interfere with the embryo's ability to attach. But it's not your biggest problem. Your biggest problem is that there are cells in the lining of the uterus called natural killer cells, NK cells. These are large white blood cells or lymphocytes that travel to the uterine lining every month, where they multiply under the effect of estrogen. And when the embryo starts to attach, they produce growth factors that regulate the growth of the roots of the embryo into the wall of the uterus. Now, there are two growth factors that play a role here. They're both called cytokines. The one is called type 1 cytokine, or Th1, and the other type 2. These cytokines produced by the natural killer cells interact with cytokines that are produced by the roots of the embryo trying to grow into the wall of the uterus. And they have a conversation. The language they use is called the cytokine network. They're going back and forth to negotiate how the roots of the embryo are going to attach. The type 2 cytokines attract the roots, and the type 1 cytokines trim down the roots much like you'd prune an overgrown fruit tree to make it not overgrow. So the balance between the type 2 cytokines that attract the roots and the type 1 cytokines that trim them down by killing off some of the cells allows the lifeline of the baby, which is the placenta, that develops from that root system to form only on the inner lining of the uterus. And so that when the baby's born, it'll come away with the baby completely. You want it to come away completely, and in the interim, to provide all the growth requirements of the embryo. In 1/3 of women with endometriosis, and that's all in that thin book and in the articles that you can get free of charge by going to my bio. In 1/3 of cases, the natural killer cells are activated. They overproduce the type 1 cytokines that trim down or kill off the roots of the embryo, and the woman loses the pregnancy before she even knows she's pregnant. She thinks she's infertile, but she's having many miscarriages so early she never knew she was pregnant in the first place. So, in some women with endometriosis, failure to conceive is the commonest cause. It is a toxic environment in the pelvis. That's the common reason why women with endometriosis often have unexplained infertility, often fail to get pregnant on their own, and so the problem is related to this toxic factor. The second is scar tissue that forms from the overgrowth of these deposits in the pelvis. The third is ovarian endometriomas that compromise the egg and the development of the egg, and therefore embryo quality in the ovary where the cyst develops. And the third are immunologic factors due to natural killer cell activation and antiphospholipid antibodies in women with endometriosis, regardless of its severity. Even before you know you've got it, there's a 1/3 chance. And if you've got that problem, it doesn't matter what we do. It's not going to matter whether we get the best embryos by doing IVF and only identifying those that are chromosomally normal or euploid, which have a 65% chance of a pregnancy, because the its roots are going to be destroyed by an immune problem. And so it's very important that all these factors be carefully evaluated, and that you understand that if you've got an endometrioma or even the mildest endometriosis, you've got to identify, quantify, and typify the variables. And in my opinion, surgery is outdated, because now we get onto the endometrioma side where we spend a bit more time. Surgery doesn't cure the problem that causes failure to conceive with endometriosis, as I pointed out earlier on. And surgery is not going to solve an immunologic problem. And surgery for endometriomas is the standard approach, and is one of the main reasons why doctors recommend surgery for endometriosis, to remove the cysts, the endometrioma, which must be removed 6 to 8 weeks before you put the embryo in the uterus. But the problem is that you don't need surgery anymore. There's a new approach we use today, and listen very carefully. All of you that are there with endometriosis, write this down. Read the articles that I'm sending you. They're very important. It's a game changer because not many doctors can do sclerotherapy. Not many doctors are aware of it. I was the one 15 years ago that introduced sclerotherapy. This is a procedure where you put a needle with a woman under conscious sedation or local anesthetic into the cyst. You don't have to do a laparoscopy. Put the woman to sleep. You put a needle into the cyst and you drain out all of the chocolate fluid, the decomposed blood in the endometrioma, and you inject a substance that causes the cyst to collapse and the walls to fuse together, so that 6 to 8 weeks later, 85% of the people who do the sclerotherapy have no longer got an endometrioma. The eggs have recovered, and now you can do IVF and get good eggs out of that ovary. In the past, laparoscopy was done, the ovary was opened, the cyst was removed, and unfortunately, in many cases, a lot of ovarian tissue came away with the wall of the cyst, removing a lot of good quality eggs, or potentially up later on good quality eggs in the process of removing the endometrioma. And now you speed up the process of diminishing ovarian reserve. So this is not good for women that have already got borderline or reduced ovarian reserve. And I've seen women with perfectly normal ovarian reserve as manifested by good AMH, anti-Mullerian hormone blood levels, come back a year later and their AMH levels on the floor because so much tissue has been removed. You can't avoid it when you do surgical removal laparoscopically. Some doctors don't remove the cyst completely, they open it up and they laser away the inner lining of the cyst wall, and that works too. But the laser is not that exclusive. It also lasers away some ovarian tissue and leaves you with the same problem. So surgery for endometriomas was a necessary evil. If you want the ovary that had the large endometrioma in it to produce good eggs down the line, otherwise that ovary has got the chance of repeatedly producing poor quality eggs. And if you've got endometriomas in both ovaries, now you can see the real problem. We don't have to do that anymore. We can do sclerotherapy. I got the idea from studying ancient Egyptian medical phenomena that they were involved in the time of the pharaohs, where they got people that had fluid around the lungs because of tuberculosis called pleural effusion, and they injected a substance into that cavity with the fluid, which caused the walls of the pleural effusion to fuse the lung against the wall of the chest, and the pleural effusion would disappear. I thought to myself 20 years ago, why not inject substances that can cause the wall of a cyst to collapse and fuse together into the cyst, and thereby get rid of endometriomas without the surgery that is painful, expensive, requires hospitalization overnight, and removes a lot of ovarian tissue, damaging the ovary and prejudicing it for future treatment. So I started off doing something 15 years ago, and I published it, called sclerotherapy. And what did I use? I used something called tetracycline, an antibiotic, but had this effect to irritate the membrane and cause the cyst to collapse. I published the work. The results were excellent in terms of getting good eggs from those women and getting rid of the endometriomas without doing surgery. But there was a big problem that nobody appreciated, least of all the patient, and certainly not me. And that was that the tetracycline we injected would leak out in 1 in 10 people. get into the pelvic cavity and irritate that peritoneal membrane, which is rich in pain fibers, causing terrible pain, which is almost as bad as having a ruptured appendix. And the woman would have to be watched for hours on end until the pain was gone and all the tetracycline absorbed. Didn't make me very popular in doing this. It cured the problem. The patient wasn't prejudiced in the long term, but they didn't like me very much, and I wasn't willing to go out there, publicize and promote sclerotherapy until we could solve that problem. A few years ago, we found a way to solve the problem. Instead of using tetracycline, we injected 95 to 96% alcohol, ethanol, and that had exactly the same effect. We would put the needle in the cyst, drain the fluid out of the endometrioma, inject 95% ethanol, leave it in there for 12 minutes, drain it out, and the woman would go home, the cyst would collapse and be gone within 6 weeks in more than 85% of cases. The complication rate was negligible. Less than 2% of people had problems, and they weren't severe. Pain wasn't a problem, and that was it. We got the problem solved. Endometrioma gone. 6 to 8 weeks later, we could go ahead and do IVF. All it required was an outpatient visit to our sclerotherapy clinic in New York, run by Dr. Ravi Kumar, which I can arrange for you after a consultation. And the person would come in for a day, do the procedure, go home. If the cyst reappeared, and it did in a small percentage of cases, all you had to do is go in and drain the fluid. It wasn't an endometrioma anymore. It just had clear fluid in it. Removing it, cyst gone, usually wouldn't come back, and you're on your way. So sclerotherapy is an outpatient procedure with virtually no downsides, with none of the risk of destroying egg-bearing ovarian tissue. Done rapidly. You can walk in, walk out a half an hour later, and you've got no problem for the future in the vast majority of cases. It's just as successful in getting rid of the endometrioma as surgery without the downsides. And it is highly successful in terms of results with IVF. A paper came out a few years ago, maybe a year ago, where someone tried sclerotherapy with ethanol, like I've just described, and reported pregnancy rates twice as high as they were getting out of removing the endometrioma surgically. So again, this is a game changer. Please be aware of it. Read the article I've given you on sclerotherapy, which you can get by linking on to the link in the bio and getting that and an article on endometriosis overall. And it deals with all of these aspects I've told you, but the main focus is on sclerotherapy. I'm going to stop here. There'll be many questions that I'll have to address, I'm sure, on this issue as we go along. But I hope you all understand how important this is. I really think that if any of you have this problem with an endometrioma and you'd like to discuss it with me, if you're doing endometriomas and someone has said to you, use Lupron, which I'm dead against for the reasons I gave in the beginning, which we can talk about, you don't need it. If someone is saying to you need surgery for your endometriosis, the only time you need surgery for endometriomas is if it's a complex endometrioma, lots of compartments to it, and you think there may be a cancer or malignant component to it, then surgery should be done. You can't do sclerotherapy in a multi-compartmentalized endometrioma, which very few are. Usually they are single cysts, but if they're multiloculated, surgery will still be required. But you do it very selectively. The vast majority of people do not require it and can get away with sclerotherapy very easily. Other times surgery might be needed is if severe pain is a major issue that you're trying to address. But then you're not doing the surgery for infertility. You're doing it for the pain associated with endometriosis. And yes, surgery is needed then. May even be an incision in the abdomen. Maybe a laparotomy. In some cases, the endometriosis is so disseminated and severe, the pain so severe, that the woman even has to contemplate radical surgery, removing the uterus or removing an ovary. That can happen. Yes, but those are by far the minimal number of cases. The vast majority, surgery is no longer required for endometriosis, and nor is Lupron required. You require sclerotherapy if there's an endometrioma, and you need the appropriate stimulation protocol to optimize growth and development of the eggs. It should be individualized. If you're older or you've got diminished ovarian reserve with an increased risk of abnormal eggs, if you use recipe type approaches, it won't help you. And if you use the right stimulation and you use sclerotherapy 6 to 8 weeks before you do the IVF to get rid of it, which you need anyway if you do surgery to recover before you can do IVF. And if you do those things and you do PGTA to know that you're putting back the right embryo, and then you only put it into a uterus that's been thoroughly evaluated for an implantation problem, which is often immunologic, which we can treat and fix. That thin book I'm giving you free talks about it, using intralipid and steroid and Lovenox. If you do it appropriately and correctly and you know what you're doing, there's no reason why you can't have a baby if we get to the point of getting competent, chromosomally normal, euploid embryos, so identified through PGTA. I'm going to stop there and let you get on with questions.
Perfect. Thank you all who have stayed in the group chat here for a minute. We have over 160 people in the chat who's been here for about the whole hour here. We've got about an hour left of today's live stream here, an hour and 10 minutes or so. And as Dr. Sher has been saying, these articles that he has in the link in bio are exclusive. They're exclusive to only you guys here in this chat. At the end of this live stream, which is, like I said, in about an hour, we remove that link. And there's 2 articles today, so we remove both of them. You will not have access to either of them. So please go check those out. If you've been here for this long, you might as well. There's so much resource in there.
Everybody who's on this webinar, everybody should get the book. There's no downside. There's nothing we ask in return. It's a gift. It was my goal and my main objective in doing these webinars is 2 things. Education and in order to enlighten and inspire. Those are the only things I want to do. I want to get rid of the myths that are out there about what you should do. So many of you are being given advice. Use Lupron. Use other forms of agonists. Use Clomid and other stimulation methods which won't work for you in many cases. Or do laparotomies or laparoscopies. You don't need those things. And if you don't also check out for the immune side, you are going to also end up with everything else looking nice and no one will know why you're not getting pregnant. You need all the variables that can affect the quality of the egg and the embryo, because it's the egg and not the sperm that impacts the quality of the embryo, and that's mainly linked to the way you stimulate it. You can't use one-size-fits-all recipe approaches. And the importance of implantation factors, such as the immunologic factors that must be taken into account, or you're getting half a treatment, and you cannot get pregnant if we put a good seed in a bad soil. Where the embryo is the seed and the soil is the uterus. You have to have a good seed and a receptive soil. So read the books. And for those of you, and I'm sure there are many, who need my input, I am available. You can get to me through that link in bio. Yes, there's a fee. Most of you in this country will have insurance that cover it. And we accept those insurances. For those of you that don't, I'm sorry, but we'll be spending hours together, and there's a very modest fee for those of you out of country. And those of you that need my input, that want to talk to me, it's well worth your while to consider it. But do it now, because it's first come, first serve, and we can only get to those that are in the front of the line. So put your name down, click on that link, get the questionnaire, fill it in right now. Only takes 4 minutes. While we're talking, get that to Patty, and she'll get back to you on Monday and set it up for you.
Awesome. We're going to start answering questions from you guys. You guys have been commenting for the last hour here, so we're going to make sure we get as many questions answered. I'm going to start with the most recent comments that come up. But first, I just want to thank all the gifters who've gifted. We kind of had a little gift battle, it looked like, for a little bit there. So Flocka83, TMP Media, Rancho Tato, and Smooth Operator. Thank you guys all for your gifts during this live stream. We appreciate that. We're going to start answering questions, so go ahead if you have an endometriosis question or a question about sclerotherapy or endometriomas, by all means drop it in the comments below, and we're going to start answering them. Alrighty. Let's see. Kiki says, can breastfeeding stop endo growing? Question
No.
mark. Simple answer. Ruby, if endo is toxic to eggs in endo environment, what about putting an embryo back into it? If an endo is toxic to eggs in endo environment, what about putting an embryo back into it? Question mark. I don't know if it's...
I don't quite get it, but you could either be asking if the environment, the uterus is not all toxic, we can fix it. If it's immunologic, we can fix that environment. The toxic environment is in the pelvis. The toxic environment is in the ovary that produces the eggs. So it's not about the uterus. The uterine abnormality that occurs with it, implantation related, is linked to natural killer cell activation and antiphospholipid antibodies, and we can address those and reverse those and take them out of the picture. So that we can fix. I don't think I understand if there's anything else that you're referring to, but if you were to, and I'm not suggesting it, 99% of you don't even have to consider this. But if you've got a problem that makes your uterus totally inhospitable, unresponsive to any treatment we can offer, you can still have a baby with endometriosis if we get a good embryo and put it in someone else. That's called surrogacy. I'm not talking about that now. That's not the subject of this conversation.
Kiki, the answer was no, it does not help. I'm going to go back over here. Nana says, what about endometriosis behind uterus? Does it need to be removed? And do you downregulate for endometriosis protocols?
Number one, you don't need to remove any endometriosis unless it's causing symptoms or complications unrelated to fertility. And that includes a lot of pain, a lot of discomfort, and if you're concerned that an ovarian endometrioma might be not an endometrioma, but the developing endometrioid carcinoma, which is a malignancy. And you can't always tell that clearly. And if it's a single cyst, that's usually not the problem. But if it's a complex cyst, then it is. So the answer is, as I just described.
Rokin says, Doctor, how can endometriosis be managed for conception to take place? Question mark.
I pointed out to you that there's a toxic environment in the pelvis. That's the main reason people with endometriosis have difficulty getting pregnant. Instead of having an 80% chance in 1 year, they got a 40 to 50% chance, maybe 40% chance in 5 years. And instead of a 20% chance in a month, a young woman has only got a 3% chance. All because the eggs are compromised after they leave the ovaries. These are good eggs. And the pelvic toxic environment makes it difficult for those eggs. So you can get pregnant if that's the only problem. But there could also be an immunologic problem that you're unaware of, even if the egg gets to a sperm, if it's the one that escapes that environment and fertilizes, which is why some women with endometriosis do get pregnant. The big problem is that once you got pregnant once, even if you were on fertility drugs or you had surgery, remember what I told you, you got pregnant in spite of it in most cases, not due to the surgery or the treatment that you received. So the bottom line is, if you got pregnant in spite of doing surgery or getting fertility drugs, you're not going to get pregnant on your own. You may get pregnant on those treatments, but when you come back and try again with the same treatments, you're not more likely to get pregnant because you didn't get pregnant due to the treatment. You got pregnant in spite of it. So bottom line, the only thing that will improve your chance of getting pregnant is IVF. I'm not telling all women they need IVF. If you're young enough and you've got time to keep trying on your own for that small chance of a pregnancy on your own, by all means. But if you're over 35 or you've got diminished ovarian reserve at any age, or you're getting up there with problems, you failed, it's time to stop and move to IVF quickly. If you do this when you're older and your chances of having a normal egg are compromised by the wear and tear effect of time on your eggs as they're developing in your ovaries, you're giving up valuable opportunity to get pregnant by trying on your own. Younger women, yes, it could just be toxic and you may be lucky. But please understand that if you do get pregnant, it's not something you want to keep on trying to do because you're not getting rid of the underlying cause of the problem.
All right, perfect. And answer another question up here. In the meantime, as you guys have already seen, Dr. Sher has multiple links in the bio. You guys can check it out. We have free articles in there, 2 exclusive articles for you guys today that are on endometriosis, sclerotherapy, and much, much more about this topic. Additionally to that, he has his 2 free ebooks you guys can get access to anytime during the week. But these articles are exclusive to today. So at the end of this live stream, which is in exactly an hour from now, you will no longer have access to them. So please go check those out.
And this is the first time we're giving 2 articles.
And this is one of the first times, we're doing 2 articles here for endometriosis. User 73 says, how do I get rid of endometriosis or endometritis if antibiotics aren't working? Thank you for the info.
Well, endometritis, when it causes a problem with implantation, in my opinion, and there are others that feel differently, it's really something that's occurred because of an ascending infection from the vagina into the uterus, infecting the uterine cavity. That doesn't happen because a woman menstruates every month. And she sheds her lining, the functional layer I spoke about at the beginning of this presentation, is shed. And the blood, in the menstrual blood itself, has got certain antibacterial properties. So from a practical point of view, you're not going to end up with lingering endometritis unless it's occurred after a pregnancy that is miscarried, where not all the products were removed, or after the birth of a child, where some of the placental tissue remained behind, and that became infected. Remember, the cervix is open after you've delivered or had a miscarriage or an abortion. So now bacteria can swim through the opening of the cervix into the uterus and frequent the dead tissue. And there are bacteria in the vaginas of all women called anaerobic bacteria. They only can grow in the absence of oxygen, and they love that dead tissue. They grow in it and they destroy the endometrium. And now you end up with scarring in the uterine lining that compromises blood flow to the lining of the uterus, and the endometrium, the lining, the soil in the plantar box, is too thin to allow the roots of the embryo to permeate. You can't grow a seed on bedrock. And now you've got a compromised endometrium. Now, there are rare conditions where you get a chronic endometritis. You don't see much of it, or we haven't seen much of it up till now in this country. But now with the influx of immigrants into this country from third world environments, we're going to see more and more of tuberculosis of the uterus. And this is something that's very, very difficult to treat. And it usually is unsuccessful if it's damaged the endometrium. But if it's non-tuberculosis, usually what the doctor is finding is really not something that's going to cause you to not get pregnant. I'm fully aware of the EMA testing that is done to check and to see if there is bacterial growth in the uterus. I'm very aware of the evaluations looking for plasma cells and all kinds of abnormal cells in the uterus. I'm telling you, I don't believe that those are big factors in preventing pregnancy with IVF. I know there's a lot of talk about it, and we do the biopsies to test for them. The ALICE, the EMA, we do those upon request. But I do it with tongue-in-cheek because I don't believe it helps. The only time there's a problem with the uterine lining, if it's too thin, is when there's been previous endometritis after a pregnancy where retained products of conception were there. And when that happens, it's a giveaway is that the lining is thin. If the lining is under 8 millimeters in thickness at the time that you start taking progesterone, or the time you get an HCG trigger in an IVF cycle, that's too thin for the roots of the embryo to be able to gain attachment, and you'll have problems either implanting or retaining a pregnancy. And I was the first to show this in the 90s. We were the ones to show that the lining is too thin because the blood flow to the uterine lining is compromised by the infection I've just described after a pregnancy-related retention of products of conception that got infected. And it's very difficult to treat, but we found a way that more than half of the women can have their problem solved if we can open up the blood flow to the lining by putting in vaginal Viagra suppositories, which work in the woman like they do in the man. They open up the blood flow to the uterus, more estrogen is carried to the lining, and you get a thicker lining. You can't use the pills. They've got to be specially compounded for absorption, and it's placed in suppository format in the vagina 4 times a day during the cycle. And many women with thin linings due to infection will now end up having an adequate lining where there's enough room for the roots of the embryo to gain proper attachment and the baby to grow and thrive.
Perfect. Wedding Coordinator UK says, how does adenomyosis and endometriosis affect pregnancy chances together?
They're completely different conditions. They sometimes coexist, but they're completely different. Most women with adenomyosis have had several children. My wife is one of them. We got 4 kids, and she had severe adenomyosis. Adenomyosis is a condition where the lining of the uterus grows backwards into the wall, like seaweed, into the wall of the uterus, constricting the blood flow to the lining, and in some cases causing a thin lining. If there's no thin lining of under 8 millimeters at the time of ovulation, at the time of the trigger shot, or at the time of starting progesterone in women with adenomyosis, it will not interfere, in my opinion, with the ability of an embryo to attach and implant. And it's not linked to the immunologic factors that endometriosis is, because it's a completely different condition. Endometriosis grows outside the uterus, and we've discussed that. It's a completely different situation.
We'll go back up here. I want to answer this one.
So if you've got adenomyosis and a thin lining, the treatment is of the thin lining with vaginal Viagra and estrogen to thicken it adequately so the embryo's roots can take hold. It's not getting rid of the adenomyoma and the adenomyosis unless it's conglomerated into a tumor in the uterus called an adenomyoma, which protrudes into the cavity of the uterus, and then you've got to remove it.
Ava and Nova says, if there's a slight suspicion of endometriosis, should that be biopsy before embryo implantation?
The old, and I should have been more diligent in explaining this to you. The old way of diagnosing endometriosis, you're always too late, because by the time you see it, it's been there for probably a decade, and you've had it even in your late teens, and causing the problems that often brings women in their mid-20s and early 30s to us with so-called unexplained infertility. And then they come back 5 years later, we find the endometriosis. But the old way of diagnosing it was by doing laparoscopy, putting a telescope-like instrument through the belly, injecting fluid into the abdomen, injecting carbon dioxide into the abdominal cavity, and looking around for these little pigeon eyes or these little gunpowder burns that represent endometriotic deposits where the pigment has remained. So that was the way to diagnose it. Don't need it anymore. That's why laparoscopy is not necessary to diagnose endometriosis anymore. You can do a test called the Reproductive diagnostic test, also known as a BCL6 test. You do a simple biopsy of the lining of the uterus. You look for these components, and if it's positive, it's diagnostic. Sometimes you can get a false positive Reproductive test if the fluid is distended with, if the fallopian tube is distended with fluid. We call that a hydrosalpinx. But in almost all cases, you'll pick up a positive Reproductive even before you can see any sign of endometriosis laparoscopically. So to argue you need surgery to make a diagnosis is wrong. Remember again, surgery does not improve your chances of getting pregnant with endometriosis unless you're removing an endometrioma, which you don't need to do anymore. You can now use sclerotherapy. So again, I want to make it very, very clear. The diagnosis by the Reproductive will become positive long before there's evidence of any visible endometriosis. And it doesn't matter how severe the endometriosis is. You've still got a problem with a potential toxic pelvic environment and the immunologic risk that occurs in 1/3 of cases. That is why surgery is redundant.
Laurie Pops on TikTok says, fellow South African, thank you for all you do for our community. We're going to answer now.
Thank you so much.
Classic Boss says, how can we normalize our hormones which are affected by endometriosis so we won't affect our health?
I don't think there's much I can tell you except that with regular checkups, your doctor checks your regular cyclicity, menstruation, your ovulation potential, hormonal levels, but that shouldn't affect your overall health until the endometriosis has gotten so severe that it's compromised ovarian function altogether, sending you into an earlier menopause in very severe cases, or the endometriosis spreads to other organs. It can go to other structures. It can go to your kidney, it can go to your liver, it can go outside of the pelvis and abdomen into the lungs, into the brain. Those extremely rare situations, but they can occur. And in those situations, symptoms will bring you to a doctor who will then evaluate you and find the cause.
Emily on TikTok says, advice on advocating for thoracic endoexploration. I suspect I formed an old rib injury.
I've just mentioned the fact that it can go to the lungs. But if it goes to the lungs, you'll usually be able to do a biopsy of the lung. A pulmonologist will do a biopsy and get the diagnosis. Very, very, very rare. But if there is an endometrioma in the lungs, they can also, I believe, respond to sclerotherapy. I don't know that for sure, but I suspect they'd respond to sclerotherapy, not something we would do, but it's something for discussion with a pulmonologist if that's the case, or excision. Or treatment with suppressants. And that's a situation where maybe antagonists like Lupron, Buserelin, and Superfact may have a role. I'm not a lung specialist, but it's something you would discuss with your pulmonologist. The first thing is to make a diagnosis, an MRI or a CT scan, and then ultimately a directed biopsy of the lesion to see what the diagnosis is important.
Awesome. Jelena, thank you for the gift. We appreciate that. Shiv, I'm going to answer your question in just a second here, but I see push notifications coming through for the articles and books. Thank you guys so much. If you're filling out the link in bio, it takes 3 minutes of your time and you get access to everything. We've got about 40-ish minutes left of today's live stream, 50-ish minutes, and we will remove those articles from that bio at the end of this live stream. So they're exclusive to anybody who's in the group chat with us right now. There's over 150 of you guys who've been in here almost religiously since the beginning of this live stream today. So please do yourself a favor and go check that link out. There's nothing wrong with it. There's plenty of resources in there. We ask nothing of you guys. No resources. There's plenty of information in there for you guys, plus those 2 articles. 2 free ebooks, 2 articles, everything you need in there. Go check that out. I'm going to answer Shiv now on TikTok. She's been asking for a second now. It says, do you downregulate for IVF endometriosis protocols?
I do mostly downregulation protocols, but not all. It depends upon your ovarian reserve. And that is measured by the AMH, FSH, LH, and estradiol. FSH, LH, and estradiol measured on day 1, 2, 3, or 4 of a regular period. AMH anytime. And based upon that, I decide upon the protocol that I need for ovarian stimulation. Now, I want to emphasize this again for you and for many of you out there that have obviously been struggling with your problem with endometriosis for a long period of time. You know, there's an old adage, doing the same thing over and over again, expecting a different result, is the height of insanity. And I think if you are having problems, this is such an important part of most people's lives, going from infertility to family. I urge you, all of you that can, to get that little questionnaire. You're not obligated. Nobody's putting you under pressure to come and talk to me. But fill it in now so that you get in line, and it's one first come, first serve. Fill in that 4-minute questionnaire that you can also get off the bio by clicking on the link. Fill it in. It'll go to Patty. She'll reach out to you on Monday and set you up to have an hour-long consultation with me, followed by a lengthy report and permanent access to me for questions and answers free of charge thereafter. So I urge you to get that questionnaire filled in. Even if you ultimately decide, having done so, you don't want to come, that's fine. Nobody's putting you under pressure. But get in line. Otherwise you won't get on, and I think I can help many of you out there based upon the questions we're seeing. Please go to the questionnaire, fill it in, do it now.
TNP Media, thank you for the gifts. We appreciate that. Thank you. We don't do any of this for gifts, but we love it when you guys give us stuff. We appreciate it so much. We're going to start answering some more questions here. I'm going to answer this one right here. Therese, I have had 2 beautiful PTTA embryos and removed both tubes and endometriomas. Can I transfer safely now? ?
Even if you had an endometrioma and you're now putting in embryos that are PGTA normal, the endometrioma should not affect it. I'm not saying big endometriomas should be left in place because they can rupture and cause acute abdominal crises. But you don't need them to worry about them inhibiting your getting pregnant. But not before you've done what? I'll let you answer the question in 5 seconds on your own. And after 5 seconds, I'll say 1, 2, 3, 4, 5. Test immunologically, or you will put beautiful embryos into a non-receptive environment and you won't even know it and you'll lost them. Don't do that. Don't let anybody tell you that they don't believe the immunologic factor plays a role. I've heard so many people say that. I'm telling you now, when somebody says that to you, you ask them a basic question. Tell me what it is you don't believe or don't understand. And most people won't be able to tell you because the area of immunology is several-fold more complex than the entire field of IVF. So I'm telling you now, don't let anybody tell you immunologic factors are unimportant. I had a lady in Australia that I treated a while ago after 24 failed IVFs at the age of 42 with severely diminished ovarian reserve. In fact, she was premenopausal. She came to the United States. We were able to just get 3 eggs from her. 1 was normal, and I'm the godfather of her child. She's a doctor herself. Her husband was a doctor. Interestingly, he was a psychiatrist, and I said to him, "You're the first psychiatrist I've met that I think needed psychiatric help. How can you stand around and watch your wife go through 24, 25 failed attempts?" And why? She had an immunologic cause of her implantation failure as the main reason she'd failed all those times, due to an underlying immune thyroid condition known as Hashimoto's disease, and no one had realized that it's a problem, and so she suffered. So I'm telling you now, immunologic testing is a very important part, and no matter what anybody tells you, and most people won't know how to advise you on that. Another good reason why we should talk, and you should fill in the questionnaire in case you want to come and have a chat with me.
Lady C, thank you for the heart. Thank you again for gifts. We appreciate that. TNP Media, thank you again for gifts. Lady C says, several rounds of IVF, 3 didn't stick, 2 implanted, lost 6 to 8 weeks, had robotic done, no endo, what now?
If you've had embryos put in your uterus that were good quality because they were PGTA normal, and you still didn't get pregnant or you lost it early, what do you have to say to yourself? The embryo is the seed, the uterus is the planter box, the soil. You've put good seeds in the soil they haven't taken, it's got to be the soil. So now you start looking for the immunologic and anatomical reasons why the soil is inadequate. I've told you one already, a thin uterine lining can be fixed. Irregularities in the uterine cavity that protrude into the cavity of the uterus, fibroids, scar tissue, polyps. All those can be treated and removed. And then the last one, immunologic. Those are not the only 3 causes of implantation problems. There are many, many others, but those, in my opinion, are responsible for the vast majority of cases of failed attachment. They need to be identified, quantified, typified, and addressed in every woman at risk of having an implantation problem. Those are women with unexplained failure with good embryos transferred, women that have got endometriosis, women that have got autoimmune diseases affecting themselves or any member of their family. And that includes lupus, rheumatoid arthritis, hyper or hypothyroidism, scleroderma, dermatomyositis, we can go on, and women that have had repeated miscarriages. Women who couples that fall into that category should be talking to me or someone like me who knows a little bit about this field of implantation and is open to discussing it. The embryo is usually regarded as it is the main factor. The seed is always the main factor. You can't plant a good seed in a bad soil. You've got to have a good receptive uterus as well as a healthy seed you're planting. And then, one other ingredient, a good gardener, the doctor, the nurses, the embryologists are the gardeners. You've got to plant the seed in the right season, appropriately and correctly done with proper support hormonally to make sure that it sticks. It's got to be done with sensitivity and proper preparation. So there's the soil, the seed, and the gardener.
Emma, thank you for the gift here. We appreciate that. We're going to answer Whitney real quick here. They said, thoughts on laparoscopy after failed transfer with Lupron suppression, ?
Well, firstly, the Lupron suppression, I've told you, is usually given for endometriosis in the form of depot injections every month. And after you've done that for 2 months, a good percentage of the women, the uterine lining forgets how to respond to estrogen because the Lupron has switched off ovarian estrogen production. So now it loses its memory and you come back and want to put an embryo in, give the woman estrogen and the lining won't thicken adequately. So it's really important to understand Lupron has really got no benefit, in my opinion. I don't use it in my patients with endometriosis. It's used for other reasons, but not fertility-related reasons. When you stop the Lupron, everything comes back to where it was within weeks. The Lupron's got a bad effect on the uterine lining. And the Lupron can cause other side effects as well. So from a practical point of view, I don't use Lupron or the equivalent, such as buserelin, Superfact, or triptyline, or other things like that, which are all agonists. I don't use them at all to prepare my patients for IVF.
Perfect. Thank you guys all for the gifts. There's so many gifts coming through right now. Thank you. Lori D says, do I need to remove a Lyme-sized endometrioma if I already have 2 normal embryos?
If you've got 2 normal embryos, if it's a large endometrioma, I would remove it, but it's not going to play a role in whether you get pregnant with the normal embryos. What is going to play a role is if, unbeknownst to you, you have an implantation problem, immunologic. So putting the embryo back in the uterus may be wasting it if what you've got is an immunologic impediment to implantation. There are only 3 labs in this country that can do the tests necessary, adequately, to give you the answer as to whether there's an immunologic implantation dysfunction or an IID, as I've labeled it. An IID, immunologic implantation dysfunction. The lab I use is in Boston. We can arrange for you to get your blood tested there. In fact, in many cases, they'll even come to your home and draw your blood if you live outside of their area. So it's very important to be able to get tested for immunologic factors if you've got endometriosis. No matter what anybody tells you, don't ignore it. Only time worth ignoring it is if you don't plan to do anything serious for your endometriosis or your infertility anyway, and you think you're young enough, you're only in your early 30s, you're going to give it a couple of years, you've got plenty ovarian reserve based upon your AMH being high, you're menstruating regularly, there's no other problems, and you're just going to try on your own to see if you can make it on your own, which you may do. Endometriosis doesn't make you sterile in most cases. It reduces your fecundity, your ability of getting pregnant per month of trying, because of the toxic pelvic effect of the endometriosis, because of scarring it causes and adhesions in the pelvis, because of an endometrioma that damages the eggs in the affected ovary or ovaries, and because of an immunologic implantation dysfunction. And because if too many of your eggs have been damaged by a serious advancement of endometriosis in the ovaries, you could end up having diminished ovarian reserve, which will mean that your eggs will be much more difficult to keep on track with stimulation. The lower your ovarian reserve, the older you are, the more imperative it is that the protocol used for ovarian stimulation be individualized in your case, not just a one-size-fits-all approach.
Perfect. I'm going to answer back up here. As Dr. Sher has been saying this whole live stream, though, we have 2 exclusive articles for you guys on endometriosis that you guys can get access to. We've got about 40-ish minutes, 45 minutes of today's live stream left, so please go check that out. It's in our link in our bio. You can click on it, fill out a 4-minute questionnaire, and get access to all the resources you need.
With nothing in return. You don't want anything.
Nothing. Absolutely nothing. There's 2 articles in there, and there's 2 free ebooks. You guys have access to it, and once you have access to it, you can return to it anytime you want. You can share it with friends, put it in group chats, put it with other people. by all means, you can do whatever you want with it. We just want you to get access to this information. There's so much of it in there. Dr. Sher has over 40 years of this experience, and he's brought over 17,000 babies into this world. So he's no one better to ask than this man himself for any kind of advice or questions about this. So please go check that out. He's written 2 books in there with his team, all free, in the bio. Check it out. We're going to answer some more questions with the remaining amount of our time, but as I said, at the end of this live stream, those articles are being removed, so go check them out while you can. Alrighty, let me see. Lady C said, are you taking new patients? Where are you located?
I do all my consultations online. I can have a much better interaction with you face-to-face online, and I do that with people from over 70 countries. And I've got babies all over the world. I won't tell my wife, but I have babies all over the world. Hardly a country I can't visit where I can visit some of my babies. One of the people was the mayor of Buenos Aires many years ago. The other one was the mayor of Istanbul. I've got babies all over the show. And in fact, I'll tell you an interesting story. One of my babies, IVF babies, is going through IVF with us right now. She herself has got infertility. So I've been around, and I want to say it again. I've only got one objective here, 2 objectives: to educate and to inspire. All the rest follows from that. When this is over, I hope I can walk away, and you all can walk away and say, right, I learned something and I was inspired by what I heard, and I've learned things that may help me maybe change course, go in a different direction. So after talking like that all that way through, I missed the question again. Do you want to just give it back to me again, Josh?
Sorry, which one?
The last one?
Let me go back up.
I don't want to.
Sorry.
I got run off on him.
Sorry, I just lost it. Hold on. Are you taking new patients and where are you located?
Oh, yes. And so I'm, in the moment, as I speak to you, I'm on the West Coast in Las Vegas. But I travel to New York, and I'm in Las Vegas, and I have my doctors in New York. The doctors I work with, I've opened over 20 IVF programs, and I've trained over 100 people in this field of infertility. But I work here in Las Vegas and through New York. Who puts their hands on and does the procedure doesn't matter. I've just pointed out, Dr. Ravi Kumar is running the endometrioma sclerotherapy clinic in New York, and she's busy. She does all the hands-on on those cases there. She's better than I am. She's done more of them. So she's very, very good. And she is also does the fertility work with Dr. Drew Tortoriello, my partner of 20 years, and myself. Doesn't matter who does the egg retrieval or transfers the embryos. We do it the same. We've been working together so long that it's like 2 peas in a pod. We do things identically. What is important is the individual approach to going through your case, individualizing your case, identifying all of the factors involved, and developing a very individualized protocol that meets your requirements. And I will do that for all my patients. I'm always involved with my patients, even if they end up doing their egg retrieval with one of my partners in New York. They still work with me and have access to me. And by the way, just so that all of you know, I have patients that go elsewhere, don't come to us, and call me on advice, and I give them advice free of charge. Once they become a patient of mine, I will always give advice with one caveat. I will not get involved when the patient is in the middle of a treatment with another doctor. That's unethical, and I wouldn't do it. Before treatment and after treatment, I'm always available, because once you connect with me and become my patient, and I consult with you, whether I treat you or whether we treat you in New York, it would be in Midtown Manhattan, 38th and 5th. Whether we treat you or you go elsewhere, I'm bound to you at the hip. I'm always available to you. So you can always reach out to me, and you will have, as all my patients do, my personal cell phone number by which you can reach me. And I ask my patients not to email or text me, because I can't answer questions in one-line answers. So I ask them to call me, and all they do is call, and if I'm busy, leave their name and phone number on my voicemail, and I always get back, always, straight away. I want to make it clear, I'm not at the stage of my life where I have to do what I do anymore to make a living. I do what I do because it's my love. I've been doing this for 40 years, and I am inspired by what I do and the babies that come into this world. If I can help you, that's all I'm interested in doing. I can't give my time completely when it comes to consultations free of charge, but they are so modest, they are so inexpensive relative to other places. That's only to give you the opportunity to gain access, because I don't need it, but I've got to cover my overhead. So I really do want those of you that feel you could benefit from talking to me to get hold of Patty by filling in the questionnaire. She'll get back to you and we will reconnect with you and see if I can help you.
Perfect. I'm going to answer Allah Mary here on TikTok, but really quick, I just want to say thank you to everyone who's filling out the bio link right now. I see a bunch of push notifications that came through, so enjoy those ebooks, enjoy those free resources, articles, and everything that comes with that. We really appreciate your time and filling out that form. Alan, or Allah, it says, adeno plus thin lining. Can more estrogen to thicken lining worsen adeno? Question mark.
If you give estrogen, let me give you a little simple example. Let's say you have a grass patch in your backyard. In the center of that patch is a dry area that's not getting any water. So you carry a sprinkler system to the dry area and attach it to the faucet. You open up the faucet. The sprinkler system, if it gets the water to the area, it nurtures it and you get a green patch of grass there. But what if that pipe that carried the water was constricted, was narrowed, was pinched? Would it help opening up the faucet more? No, because no more water is going to get by to the sprinkler system and the grass isn't going to grow. You've got to replace the hose with one that is open to carry the water to the area. The blood vessels carrying your estrogen to your lining is the hose carrying the water to the dry patch. The dry patch is the thin lining. The adenomyosis constricts the blood vessels by causing pressure because it goes through the wall like getting through there like seaweed, and it constricts the blood vessels. The use of vaginal Viagra opens up the blood vessels. Now by giving more estrogen, that means opening up the faucet more, you get more estrogen delivered through the hose pipe to the dry patch, the thin lining, and you get a thick lining developing in most cases. If you can thicken the lining by doing that, you're home and dry. The adenomyosis is not important. If you cannot get it to thicken, you've got an intractable problem. And I hate to say that under those circumstances, your uterus might never be able to carry a healthy pregnancy. And I'm going to take 3 minutes of your time to explain something that to me is the most important part of what I do. It's what drives me. I'm board certified also in the field of maternal fetal medicine, high-risk pregnancy. For many, many years, I treated people coming and referred to me and transported to me by air and by ambulance with problems in pregnancy. I saw so many women come in with babies that didn't develop properly in the uterus, that were starved and were born small for gestational age with placental starvation insufficiency. I'm telling you, having gotten into the field of IVF, I've come to realize that events that precede your ever getting pregnant can affect the quality of life after birth by creating an adverse environment in the uterine lining that cannot nurture the developing embryo. If the lining is abnormal because it's too thin, or the lining is scarred, or the lining's got an immunologic component, that embryo will usually not even attach, or attach and miscarry in most cases. But God forbid, in some cases, the baby escapes it and develops with a compromised lining. Now it's forced to try and survive in an adverse environment. So the placenta, the lifeline, doesn't develop properly. And now you've got a baby starving all the way through its development. The doctor's forced to rush in and deliver it because the baby becomes distressed, malnourished during development. And the timing of that delivery is critical. And so that the baby may be born compromised in development. The last organ to be affected adversely is the brain. The body usually is affected first, all the other organs. So the baby doesn't develop physically in the uterus the way it should. And at the last stage of it, The development of the neurons in the brain is affected. So you may be giving birth to a baby that is compromised from events that preceded you getting pregnant and that could have been addressed before you did fertility treatment. If somebody looked at them in advance, identified them, quantified them, and corrected them, you might have not only been able to get pregnant and have a baby, but that baby might have had an optimal potential for subsequent development. It is the quality of life after birth far more important than life itself, in my opinion. My job isn't to get women pregnant. Yes, that's the start of it. My job is to get women pregnant and give them an optimal potential to have a healthy baby and for that baby to thrive. If I can't achieve that, I must get out the way. And everything we talk about is geared towards helping you get a healthy seed embryo into a healthy uterus, a healthy planter box, a good soil and a good seed, and plant the seed delicately. The goal, to help you have a healthy baby, not just get pregnant. And if I don't succeed in that, then I'm not doing you any good. I'm doing you more harm by getting you pregnant than not.
Awesome. If you guys have been in here for a minute and still have not gotten your question answered, please just shoot us a DM. We have a very large team that will reach out to you. We'll give you all the resources through there as well. But if you haven't gotten your question answered and you're still enjoying the live stream as well, go check out the link in our bio. There's 4 resources there for you guys. 2 free articles that Dr. Sher wrote for you guys today, exclusive for you guys. In 25 minutes, I'm going to take them off of the bio link, and you will no longer get access to those articles. They're exclusive to everybody who's here in the live stream with us today for today's seminar. And additionally to that, we have our 2 ebooks that are in there that Dr. Sher has written with his team out in New York. They're there all times during the week. You can get access to them anytime in our link in bio. But the articles are exclusive to today. So go check those out while you have the chance now. We got about 20-ish minutes left of today's live stream. It's been an awesome one, guys. So thank you so much for all the comments and all the engagement so far. We are still at 160 plus people in the group chat right now.
That's still
commenting. So we're ecstatic, guys. Thank you so much.
And again, guys, talk to me. I'm not twisting your arm. If you talk to me and say, Dr. Sher, I live in Timbuktu, I can't come and be treated by you guys. I will still be happy to talk to you and give you advice. And by the way, I get calls from doctors all the time asking for advice if that element called arrogance is gone. Some doctors are a little bit too arrogant to even ask for advice. And I understand that. It's not easy to go to someone else in the same field and defer to them or even ask their advice. But there are some guys, and I admire them more than you realize, who call me and ask me, and I do my best to help. But you can't always help by telling somebody else how to do it. It's like you telling me, if you're a good baker, how to bake a good cake. You can give me the best recipe in the world, I'll screw it up because I'm not able to know when to juggle and change and adapt. And most of the things that make you good at what you do is seasoning, knowing when to make changes and adaptations. And many people who just learn from me or from a book or from an article on how to do something are not going to know what to do when things don't go exactly as they wanted it to go. And my goal is to do that for you and to be there for your doctor if they call me. It's not about trying to rope you in. So I'm urging you, get to the questionnaire, click on it, get your name down, be first in line or be early in line so Patty can get back to you, and then you can make up your mind. You don't even have to have the consultation. When she calls you to set it up, you can say, I changed my mind. Nobody's going to go for you. It's just a question of having that opportunity available to you. Get that questionnaire answered now. Answer it while you're on the live feed so that you get your name down in time.
Yes, ma'am. Shanice, if you fill out the questionnaire, you'll get access to everything as well. Let me go down here. There was another question. Lady C, thank you for the gifts as well. I'm going to answer your question as well. It says, I'm trying to set up a consult. It's asking partner info, and I don't have a partner. What now? You can add zeros and NAs into it, and then when you have a conversation with Miss Patty, you can just let her know your information, and that all gets referred to Dr. Sher.
And Patty will be more than helpful. If you can't fill in something on the questionnaire,
absolutely,
you just say to Patty, here's what I didn't know to fill it in, and she will do it for you. She will help you. Patty is probably, of all the people I've ever met, one of the kindest, sweetest, and most unbelievable people I've known. She's worked with me for 7 years. best person I've ever worked with. And my patients love her a lot more than they love me. And I'm glad of that. She builds relationships with them. She's what you call a horse whisperer. If any of you know what that is, she's got a ranch and her horses walk behind her like dogs, cats behind their boss. They love her because she's that kind of person. She cares. And she will be there for you too. So call Patty. She'll help you fill in anything you have difficulty with.
Awesome. A lot of thank yous from the group chat here. Lori D says, Patty is awesome with 2 exclamation marks. They also said earlier that they have a consultation with you in 2 weeks. So
I look forward to that. I'm really booked ahead, but I will fit everybody in if you get your name down now. That means fill in that consultation request. You're not obligated to me. There's no pressure. There will never be solicitation by anybody in our team ever.
Perfect. Kathy says, I'm currently in the process of IVF. Is there anything I can do to prepare my body for a transfer? ?
What you can do, eat well, sleep well, exercise moderately, live your life, don't take any drugs. Alcohol is a drug. Stay away from it if you can or have very little. If you smoke, stop during this time and then probably when you're pregnant for sure. And the most important, keep your mind open and understand the basis of everything in life. Man proposes, God disposes. We may be able to do all these wonderful things with His grace, but nothing is going to work unless He wants it to. The strongest power you have in what you're doing is prayer. Pray. I'm not trying to push it on anybody, but I believe very strongly, I've seen it with my own eyes, cases where people got pregnant where I never thought was possible. Others not get pregnant when I thought they'd get pregnant in a heartbeat. No man makes a decision. We set up the cards. He sets up the cards for us. We play them the best we can. But we're not in charge here.
Beautiful answer. Lauren says, what protocol do you suggest for FET following LAP for endo?
Again, the protocol of FET is something I can give to you when we talk. If we have a consult, I will send you that protocol in writing. It's in my book. One of the 2 you're getting, there's a protocol there as well of how we do it. What I basically do is I put women on a birth control pill for a short while to get their ovaries to get a breather. I overlap the pill with Lupron for a couple of days, stop the pill, continue the Lupron. They have a period within a week. When the period starts, we start them on estrogen. I don't use oral estrogen. I don't think it absorbs nearly as well as when you give it by injection or by transdermal skin patches. So I use the injectable estrogen format where they get an injection twice a week, measure the blood levels of estrogen the day before we give the next shot to know how to adjust the upcoming dose. Check the lining by ultrasound to make sure it's good. And then when that's done, and the estrogen level has reached the 500 to 1,000 picograms per milliliter level, which is where I want it to be. And the lining's over 8 millimeters. I'll never put embryos into a uterus of under 8 millimeters because it'll usually be lost or the pregnancy will be compromised. And if it's over 9, it's perfect, especially if there's a triple line. And as I told you, I was the first person to show this in the mid-90s. And then put the embryo into the uterus 6 days after starting progesterone injections in the form of progesterone in oil, along with estrogen and progesterone vaginal supplementation. And after the embryo is in the uterus, we can switch from injectable estrogen to vaginal injectable progesterone in oil to vaginal progesterone in the form of quinone, 8%. And that works extremely well, and then you can stop taking the shots. So that's a quick overview. I will discuss that with you if we have a chat. It's not good enough to just go and have an embryo transfer. You've got to know whether you're putting the embryo in a receptive environment, no matter what you're told. You need to do that, in my opinion. There are those that will differ with me, and I accept that. Nobody agrees all the time with everything. But I'm telling you, with 40 years of experience, in my opinion, that's very important in women with endometriosis.
Yasmin on TikTok said, I have endometriosis, not following any treatment, only on regular consultation, and things are great. I'm sorry, I thought there was another question. My bad. I thought that was a full question. Endometriosis stage 4, adeno and kissing ovaries with cyst in ovaries. Any chances to do IVF? That's
Absolutely, you get rid of the cysts, the endometriomas, and you use sclerotherapy. Especially if both ovaries are involved, going to do surgery on both ovaries could deplete a lot of your egg-bearing ovarian tissue. So you need to do sclerotherapy. Forget about the kissing ovaries. Forget about all the other things going on, and the adenomyosis. Your next goal is, can you get a thick enough uterine lining, and is the uterus regular inside? And that requires a saline sonogram, or it requires a hysteroscopy to make sure that it's smooth inside. And then you need to make sure that the lining can get to 8 millimeters at least at the optimal time of estrogen treatment. If it's not, it doesn't reach 8 millimeters, you can do a therapeutic trial with Viagra and estrogen, and in more than half the cases you'll fix that problem, and then evaluate for the presence of an immunologic issue, fix that, put the embryo in, and you could still have a baby, provided you've still got eggs. All depends on your ovarian reserve, and of course getting rid of the endometrioma so that the eggs that are in the ovary after doing so have a chance to recover before you take them out and fertilize them.
Fur Babies on TikTok says, hi, good day. May I know if Dynogest, Viacin 2 milligrams is effective for endometriosis for 90 days?
I wouldn't use it. In the same way, I wouldn't use Lupron.
Alice Thomas says, stage 3 endo. My pain has been better since surgery, but I get back pain doing any task. Is that endo? Question mark.
Could be. Could be endometriosis, can be anywhere. But the surgery probably removed a lot of the lesions. And I repeat, surgery for pain due to endometriosis is often very, very successful. But not if you're doing it for fertility. And oftentimes you've got to prioritize which you're going to do first and place where you're going to put your attention first. But surgery, and there is a form of surgery that will eliminate most pelvic pain with endometriosis. I did it on not my grandson, my nephew's wife. She has now got a child, but you do a procedure called a presacral neurectomy. Presacral neurectomy, where you cut the nerve that feeds the pelvis and causes the pain. I did that on her, and her pain with endometriosis was gone. So presacral neurectomy is something a lot of doctors don't like to do because they're not trained in doing it anymore. But it's something that can be done through a laparoscope if you're doing the endometriosis for pain. But if you did the endometriosis because you want to have a baby, you don't need surgery. Surgery isn't part, in my opinion, of fertility treatment for endometriosis any longer, with the introduction of the BCL6 receptiva test, with which we can now diagnose endometriosis without having to do a laparoscopy, which in any case diagnoses it pretty late on in the game, and with the advent of sclerotherapy, which we do through our sclerotherapy clinic in New York with Dr. Ravi Kumar, and where I can get you set up pretty easily.
I think...
Let me say another thing. Again, let me emphasize. Sclerotherapy for endometriomas is where the endometrioma is a single cyst, unilocular. If there are lots of septa and it's all divided up, we can't do sclerotherapy. Then surgery may be needed, so there's still place for surgery, but very, very limited in my opinion.
I think I have a two-part question here. It says, I am currently in the process of IVF. Is there supplements I can take to prepare my body? I'm currently 32 weeks pregnant. I have no amniotic fluid, and my baby kidney are enlarged. Could this, and then it gets cut off.
Okay, I'm a little bit concerned about the no fluid and the no amniotic fluid. That's often the first sign of placental inadequacy, placental insufficiency. We spoke about that earlier on. Sometimes a baby with no amniotic fluid is running out of steam and needs to be taken out of the uterus earlier than you ordinarily would. Being born too soon can be born too late if the baby is running out of placental function. So it's really important for them to check and see if the baby's lungs are mature. Very often, and I did a research and I did a thesis on this, if a baby's under that kind of stress that I mentioned, the good Lord and nature accelerate the process of the baby's organs preparing for the outside world. And so they go into a state where they mature prematurely. The first organ to mature prematurely is the lungs, because that's the one that's got to breathe when you're born. So if you test the baby by testing the fluid around the baby, and you find at 32 weeks that the surfactant, the thing that makes the lungs function properly, produced by the lungs, is being overproduced, it often tells you the baby's in trouble and has to get out. And with that, plus placental efficiency testing, you can tell whether you need to get the baby out before it's too late, put it in an environment where you can do something about it in the pediatric neonatal intensive care unit. The second thing that bothers me is the large kidneys, because part of the fluid around the baby is fluid produced by the urine that the baby urinates into the fluid. If there's anhydramnios or oligohydramnios, it sometimes means there's a problem with the kidneys. So you need to get yourself to a high-risk perinatal specialist, maternal fetal medicine, so sophisticated ultrasounds and testing can be done of the baby to make sure it's urinating, to make sure that your lack of fluid around the baby isn't due to the kidneys not functioning. You've got to know what you're dealing with and know quickly and know what's going on before you make a decision on what to do. And that's putting on my maternal fetal medicine hat.
Alright guys, you've been in here for a minute. You guys already know that there's free resources in our bio, but you might not know that in 10 minutes the access to the articles will be removed from the links in the bio. There will be no access no matter what way or what direction you try to get to it. It will be deleted off of the overall pages, so go check those out. Those articles are handwritten by Dr. Sher for you guys specifically today. They're exclusive for these live streams. We write a different one each week, or Dr. Sher writes one each week. But today he wrote you guys 2 articles.
Can I ask you?
Yeah.
Do you know what our next webinar's on? Can you remember?
I don't remember what that topic is the next week. I just know it's Thursday. It's the next week.
Maybe while I'm answering your question, you could maybe...
Yeah, I'll look it up real quick after this.
Because we need to tell them what the next...
Absolutely, absolutely.
Next Thursday is the date of my next webinar. Please spread the word. Many of you, especially those with endometriosis, are in chat groups. I can't tell you how important and helpful it is if you go to those chat groups and invite people to come to our webinars. If you could do that, if they're interested in the topic. I'm going to tell you the name of the topic because Josh is looking into it now.
Frozen embryo transfer, FET.
I'm doing my webinar next Thursday, 4:30 p.m. West Coast time, 7:30 East Coast time, on frozen embryo transfers, how we do them, how we prepare for them, how they've changed, how they work in conjunction with PGTA or genetic testing, which, as many of you know, was developed by Dr. Tortoriello and I 20 years ago, now used all over the world to tell which embryos are the best. The whole perspective of frozen embryo transfers has changed. The way you prepare the uterus is important. It's a big webinar I'm going to do. And I'd really like to invite all of you, get the word out there, please, to those of you that are in chat groups, spread the word out, send out the emails, invite people to attend. I look forward to doing that webinar next Thursday and look forward to having you all attend and participate.
Thank you. And Am, we're going to answer your question here on TikTok. It says, how can I thicken my uterus lining? Estrogen and vaginal estrogen didn't thicken it? Question mark.
Well, remember I told you the story about the sprinkler system on the patch of dry grass and the hose pipe that is connected to the faucet. The faucet is the ovary. The pipe carries the estrogen, which is the water, to the sprinkler, and the sprinkler system is the lining. If you've got problems with your uterine, the delivery of estrogen through the blood vessels, which is the hose pipe, to the sprinklers, to the lining, if there's a problem with estrogen delivery, it's very often because the blood vessels are constricted by adenomyosis in some cases, but usually infection in the past. And there are other reasons as well, If that lining is thin, it won't help you giving more estrogen. You've got to open up the hose pipe, and that requires vaginal Viagra suppositories placed in the vagina 4 times a day, and that will open up the blood vessel, allow more estrogen to flow, more water to reach the sprinklers, and you may get a better lining in more than half the cases. If the lining's under 8 millimeters, you got a problem.
Nanami, thank you for the heart and the gift. If you have a question, let me know. I'll answer it again here.
Take one more and I'll make a closing.
The closing. All right, so we'll answer one more question for the day, guys. We're going to give you a second to type your comment, to ask your question. The one that I see the most will answer. So go ahead and spam your comments here. Whatever I see the most here will get answered today. I do, really quick, Dr. Sher, I want to get Nana answered just out of the way, and then we'll do one more. So what do you think of endo test was their question.
Endo test.
Endo test. What do you think of endo
test?
test?
I don't know what she means by endo test. What kind of endometrial test? Maybe I should look it up. I don't know.
No, let us know what kind of endo test you mean by that.
Why are you going? I'll quickly go to my... Often it's got their new tests and their names that I'm not aware of, so let me look. Go ahead.
In the meantime, guys, we have one more question that we're going to answer, so I'm going to let them all comment your question. We're going to answer one last one for the day. For the rest of you, if you have not gotten your question answered you've been here for a minute and not gotten your question answered, please DM us. Like, we have a huge team that will reach out to you. We'll give you the resources and information if we can't answer something. But we've got a very smart and educated team. She says salvia test to detect endometriosis.
A what? A saliva test?
Saliva test. Sorry, not salvia.
I don't think it's of any value, frankly.
Cool. All right. I'm seeing girl math more than anybody else here, so we're going to answer girl math's question for the last question of the day. If you guys did not get your question answered, please, like I said, go DM us, go check the link in bio, go get access to the resources before we end the day's live stream. We're going to end in about 5 minutes here, and like I said, those articles will be removed.
I've just pulled up an article which conflicts with what I just told somebody. It says that the endo test is very sensitive. It's a new test that's just come out. I didn't even know about it. You just educated me, and I thank you. It says 97% sensitivity detecting women who've got endometriosis. It may be equivalent to the Reproductive test, and instead of doing the biopsy in the uterus, you could test the saliva. It has 94% specificity identifying women who did not have it. So it tells you 97% certain of those who've got it, and those who test negative don't have it. So it should be interpreted alongside symptoms and other things, and other testing. It's made in Europe. It came out in July of this year.
Oh, very
wow.
Cool. Very cool.
I appreciate you telling me this. It's different from the Reproductive diagnostic test, they say, because it uses saliva, but it measures the same thing as I suspected. It examines, So it may well be a new thing. Thank you. I'm going to research it myself. This is something I wasn't aware of.
We learned something.
I've just learned something from you, and if I had a hat, I'd tip it to you. Thank you for that question.
All right, Dr. Sher, last question of the day. Girl Math finds, as promised, says endo stage 4 cyst in both ovaries. Test results AMH at 23 at age 31.
Well, if your AMH is 23, I'm clear that you're not from the United States.
Laparoscopy first of IVE or IVF.
Okay, so if you've got an AMH that high, done in Canada, the UK, or South America, Australia, wherever, where they do this test, they measure the AMH in picomoles per liter, which I'm sure what you're talking about. You've got good ovarian reserve, means you've got lots of eggs. So you've still got a pretty good chance, provided did she say she had endometriotic cysts?
I don't have any information of that.
What did she say?
It says, let me see, endo stage 4 cyst in both ovaries.
There you are, you've got endometriotic cysts. You need sclerotherapy. If you're anywhere near us, you need to talk to me so I can get you in with Ravi Kumar to do sclerotherapy on those cysts if they're over 1.5 centimeters in size. And since both ovaries are affected, if they are large enough, you're going to have bad eggs from both sides. And that can be avoided if it's treated up front, in my opinion.
Hey.
Okay, so I've got a final swan song here, and that's always a thank you. I mean, I so appreciate you guys coming. I don't think you realize that my goal
is to keep on building the following we're getting, and we're getting more and more people following us all the time, and it's growing and growing. When we reach a certain point, my goal is to set up a podcast on infertility, which I'll do on a weekly or 2 weekly basis, and invite guests that are experts from all over the show to come and join us and answer your questions. I'm not there. I'm only going to get there when these webinars grow so big that we can meld them over into the podcast. I'm asking all of you again, get this information out to your people in your chat rooms or friends that have a similar problem. Spread the word, bring people to our webinars, and share all of the information you get with us, the books and everything else. Share them. I don't want anything for them. I've written 7 books. This has not been written to make money out of it. I wrote it because of this basic 2 things that bring me here. 2 things that I want to leave in my legacy, more than all of the other breakthroughs. I was able to inspire and educate. If I can do those 2 things, everything I'm doing is worthwhile. That's why I'll keep on doing these webinars. Remember, the next one on frozen embryo transfers will be next Thursday, and please spread that word around.
Thank you all. You will have about 3-ish, 4-ish minutes to go fill out that questionnaire and get access to the rest of the resources.
Again.
And yes, if you guys want to rewatch today's episode or any of the last episodes that we've done on any of the topics that Dr. Sher speaks on, he has a new topic every week. As you just heard, FET is next week on Thursday. Every week we record these sessions. We've got a big camera over on the left of me that you can't see right now that records all of it. We upload them to Spotify, YouTube, Amazon Music, or Amazon Prime, Apple Music, and a bunch of other platforms. So if you guys can't or didn't get a chance to listen to today's live stream, please go check that out. We have multiple resources at Dr. Geoffrey Sher on all platforms. There's only a few minutes left here that I'm going to leave that articles on the link in our bio. So go fill out that questionnaire. You get access to everything. In about 4-ish, 5-ish minutes, you will not have access to the articles. You will still have access to the ebooks, so go check that out. It's been a pleasure, guys. Thank you so much for joining us, and we'll see you guys Thursday.
Thank you.